Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I'm here to talk today about PrEP for people who inject drugs, and I have titled this talk Challenges and Opportunities. So I'm not going to spend a lot of time reviewing sort of the epi, but rather get into some of the data on delivery of PrEP for people who inject drugs. And I think we'll spend most of the time hopefully talking about the challenges associated with that. So I have no financial disclosures. I'd just like to acknowledge Jihan Budak and Sarah Glick, from whom some of these slides are taken. So just a brief background to start. I think many of you know about the epi of HIV as it pertains to people who inject drugs, but data from the CDC in 2019 showed that people who inject drugs accounted for an estimated 7% of new HIV diagnoses, with MSM and IDU accounting for another 4%. And although this is, a relatively low percent in comparison to other risk categories, it's been relatively stable over the past several years. And we haven't made all that much headway in terms of prevention of HIV amongst people who inject drugs when it comes to PrEP. And indeed, over the past several years, there have been a number of outbreaks of HIV amongst people who inject drugs, the most notable of which you probably heard of in Scott County, Indiana. That was several years ago. And there have been local outbreaks as well here in Seattle and also in Portland. And as many of you know, the strongest evidence supporting the use of HIV PrEP for people who inject drugs comes from the Bangkok Tenofovir study. And this was a double-blind randomized controlled trial of TDF versus placebo. So notably, it was TDF and not TDF-FTC in 2,413 people who inject drugs in Thailand. And persons between the age of 20 and 60 who had injected drugs in the past year were eligible to enroll, and they were randomized in a 1-to-1 fashion to receive either TDF or placebo. And between June of 2005 and July of 2010, about 1,200 participants were enrolled in the TDF arm and about 1,200 in the placebo arm, and the baseline characteristics were similar. In total, 80% of the study population were male and 81 were between the ages of 20 and 39. 63% had injected drugs in the past 12 weeks, with 32 reporting at least weekly injection. And this was mainly methamphetamine, midazolam, which is something we don't really see here, and about 22% heroin. Sexual risk factors were also common in this population. And what you probably remember from the study is the data presented on this slide, where it was found that TDF had a 49% risk reduction in incident HIV infections. So over the 9,665 person years of follow-up, which was an average of 4 years per person, there were 50 new HIV infections, 17 in the TDF group and 33 in the placebo group. And this represented that 48.9% reduction in HIV incidence. So this is really the strongest evidence we have that PrEP works in people who inject drugs, and the only large-scale randomized controlled trial in that population. And so because of this trial and because of our experience with PrEP in people with co-occurring risk factors for HIV, CDC has recommendations to use PrEP in people who inject drugs. And this is the schematic they included from the newest 2021 update, where they're recommending that people who have ever injected drugs be screened for PrEP if they have injected drugs in the past 6 months and have shared injection equipment. And that's not just syringes, but any equipment, including cookers, cottons, waters, etc. Then those individuals be prescribed PrEP. And of course, anyone who requests PrEP should also be prescribed it, as we know that many times people aren't endorsing all of their risk factors to healthcare providers. And then CDC also has this box up here in the corner just saying to assess for sexual risk factors as well. And I will say that's something that I think is oftentimes overlooked in people who inject drugs. There's a lot of co-occurring sexual risk factors, particularly amongst women who may be engaging in exchange sex for money or drugs. So that's all I'll say about the background. I know this is a pretty educated group in terms of PrEP and PrEP delivery. So let's take a bit of time to talk about the challenges in implementation of PrEP for people who inject drugs, because I think that's really where a lot of more recent data is focused. There are several studies that show us that PrEP is really poorly utilized amongst people who inject drugs. And so I've highlighted 3 of these studies here. There was a study in Baltimore that looked at 265 HIV uninfected people who inject drugs and found that of those 265, only 2 or less than 1% were currently taking PrEP, despite 43% being eligible for PrEP based on their injection behaviors alone. Data from Philadelphia from the NHBS studies similarly show that a low percentage of people who inject drugs are receiving PrEP. So from NHBS data in 2015, only 2.6% of HIV-negative PWID who were surveyed had received a prescription for PrEP. And similarly in San Francisco, a survey of PWID found that only 3% were taking PrEP. Data from Miami similarly shows a very poor PrEP care cascade for people who inject drugs. So this is a study out of a Syringe service program in Miami where they surveyed 152 people who inject drugs who were accessing syringe services. Of those 152, 43 had ever heard of PrEP, so relatively low awareness of PrEP in this group. And 35 of those individuals were interested in PrEP linkage, although only 2 set an appointment with a doctor, and in the end, 0 received a PrEP prescription. More local data from the Seattle area shows similarly low uptake of PrEP amongst people who inject drugs. So this figure here is showing data on PrEP awareness and use of PrEP from 3 different studies. So on the left-hand side is the 2015 National HIV Behavioral Surveillance Survey, which I've referenced just a few slides ago, which for those who aren't familiar is a CDC-sponsored survey of people who inject drugs. It alternates years between people who inject drugs, people who are at high risk for HIV from heterosexual sex, and then amongst MSM in the 3rd year. And in the 2015 NHBS survey, only 13.2% of PWID here in Seattle and King County were aware of PrEP, and less than 1% were actually using PrEP. The awareness of PrEP increased in 2018 to 26.9%, but use of PrEP was similarly low. And then data that Sarah Glick and I published from a 2019 survey of people accessing syringe services here in Seattle showed that awareness was actually about 51%, so relatively higher. But again, these were people who were already engaging in syringe services and harm reduction services. But still uptake of PrEP or use of PrEP was low at 0.8%, despite 44% being interested in PrEP. So I think collectively, this shows us that while even with awareness and sort of interest in PrEP, uptake remains low. And in fact, this is what was shown in a systematic review of PrEP uptake and interest in PrEP amongst people who inject drugs, where the systematic review that was published 2021 showed that PrEP awareness across different studies ranged from about 1% to 57%, so widely variable. And actually risk perceptions ranged from about 1.1% to 66%. So again, a wide variability in the proportion of people who inject drugs who actually think that they are at risk for HIV. And then amongst the studies that were reviewed in this systematic review, factors associated with willingness to use PrEP were also varied, and they included things like perceptions of one's risk for HIV, the availability of appropriate support services, being female gender, identifying as bisexual, homelessness, and having other medical comorbidities, which may be a marker for engagement in care, and then being PrEP eligible. But I wanted to hone in on this kind of perception of risk idea a little bit further and these kind of co-occurring needs amongst this population. And I think one of the biggest barriers for people who inject drugs is just the fact that so many of them are experiencing so many other urgent medical needs or urgent social needs. And so what you're seeing here is a word cloud from a 2015 Syringe Service Program survey of people who inject drugs here in Seattle, where people were asked what is their single biggest concern about their health right now. And the words, obviously, that are bigger are the ones that were mentioned more frequently. And you see down here that HIV, while present on the survey, is not necessarily represented as the biggest concern for folks, with drug use, getting clean, and even viral hepatitis being much bigger concerns for individuals. And we see similar data out of a NHBS survey from 2016 that specifically targeted women who are exchanging sex here in Seattle. And women who are exchanging sex were also asked, what is your most important medical concern right now? And most of them identify things like mental health, dental care, and general primary care as their largest concerns. And infectious diseases such as STDs, HIV, and hepatitis represented a much lower proportion of people's immediate medical concerns. And I think all of this in terms of kind of folks' prioritization of their healthcare is also situated within the opioid crisis and drug overdose crisis that we are seeing, which has only been exacerbated by COVID-19. Provisional data from the CDC's National Center for HIV Statistics indicate that there were an estimated 100,306 drug overdose deaths in the United States during the 12-month period ending in April 2021. So again, these data are about a year old, but this was a 28.5% increase from 78,000 deaths during that same period the year before. So we know that in addition to unstable housing, multiple medical comorbidities, people who inject drugs are also experiencing higher rates of overdose, including fatal overdose and loss within their community, which I think also makes it, harder when we're thinking about talking about prevention measures for something that may not seem as imminent to them. And then I'll just say that, some qualitative data from folks who are accessing syringe services has indicated that HIV and Hep C testing has also been down during the pandemic. So that kind of adds to the challenges of prescribing PrEP and talking about PrEP for people who inject drugs. So these harm reduction services that have really been kind of mainstays of prevention for both bloodborne pathogens and for opioid overdoses for people who inject drugs have really been hit hard by the COVID-19 pandemic, and many services were temporarily and even more kind of long-term altered by the pandemic, and the way that services have been delivered have made it more challenging for people to actually access HIV testing. So now that we've kind of reviewed some of the barriers to providing PrEP for people who inject drugs, I just wanted to take the second part of the talk to highlight some of the strategies for service delivery and things that have been tried in terms of PrEP delivery amongst people who inject drugs. So I will kind of preface this by saying that there are relatively few data on concrete strategies to improve PrEP uptake for people who inject drugs, and also on sustained use of PrEP in people who inject drugs. And a lot of the novel strategies that you probably have talked about on this forum, like home PrEP, teleprep, community pharmacy-based PrEP, on-demand PrEP, things like that, may not be well suited to people who inject drugs. So I wanted to start off with some local data. This was a qualitative assessment of PrEP services in King County, led by Sam Benson and Sarah Glick. And they interviewed 18 service providers and 27 people who inject drugs to try and understand how can we better deliver PrEP services here in Seattle and King County. And the conclusion from these interviews were that overall support for PrEP services was high amongst service providers and people who inject drugs. And the thought was that this should be on the menu for people, but not at the expense of other interventions. And there were 3 kind of potential models for PrEP delivery that were suggested during these interviews, including a drug user health center, which would be a fixed site addressing a range of services on a walk-in basis, mobile outreach, and then add-on services to existing service providers, including syringe service programs. And so these types of models have been tried in other parts of the country. And specifically, when thinking about integrating PrEP into syringe service programs, there is some data from Philadelphia looking at PrEP delivery for women who inject drugs and are accessing syringe service programs. So this study here was a demonstration project of integrating PrEP into SSP services for women who inject drugs. It enrolled women who inject drugs that were 18 years of age or older. Of course, you had to be HIV negative, and the women couldn't be pregnant or planning to become pregnant during the study period. And they were educated about PrEP and offered 24 weeks of daily PrEP at the Syringe service program. The participants completed surveys and clinical assessments, both at baseline and then at week 1, 3, 12, and 24. And then laboratory evaluation also included TDF drug levels that were measured in the urine at 3 months and 6 months to measure adherence. So in total, this Syringe service program enrolled 95 women. Most of them were homeless, and about a third of them visited the SSP at least a few times a week, and 16% visited daily, so they were a relatively engaged group. Nearly half reported sharing some syringes in the past 6 months, and many had engaged in transactional sex and reported inconsistent condom use. But despite this, the perceptions of risk for HIV were rather dichotomous in this group. About 54% reported that their self-perceived risk for HIV was extremely or very low, despite high rates of HIV risk behaviors. So of the 95 women who enrolled, 69 received a prescription for PrEP in week 1, and 43 were maintained on PrEP by week 12. There were 5 women who initially did not receive a PrEP prescription but later enrolled by week 12. And then of the 48 women who inject drugs on PrEP at week 12, 23 persisted by week 24. Unfortunately, despite many women persisting, and despite about 50% of women reporting consistent adherence to PrEP at week 12 and reporting consistent adherence to PrEP at week 24, which is what you're seeing on the left side of your screen, only one participant had preventative tenofovir levels in urine by week 12 and week 24, indicating that the overall adherence to PrEP was very poor in this group. They did do a multivariable analysis looking at factors associated with PrEP uptake, and PrEP uptake in this group was associated with frequency of SSP access, inconsistent condom use, and sexual assault. And then retention in care was associated with frequent SSP access. So authors from this study concluded that SSPs are promising locations to reach women who inject drugs who would benefit and are interested in receiving PrEP. But importantly, and perhaps not surprisingly, women who inject drugs will need additional support to adhere and persist in care. So the next study I'm going to go over is a study looking at coupling PrEP with hepatitis C treatment and also with treatment for opioid use disorder. And this was a study termed the ANCHOR study, a different ANCHOR study than the ones you guys have recently discussed here related to anal cancer screening. But this study evaluated a community-based care model that co-located Hep C services, medications for opioid use disorder, and PrEP in both Washington, D.C. and Baltimore. Individuals were enrolled if they were Hep C RNA negative and had opioid misuse within the past year. And based on site characteristics, those who were in the Baltimore site were all on medications for opioid use disorder, whereas participants in DC didn't have to be on medications for opioid use disorder, but could be if they so desired. And so patients were included in the study if they were eligible for hepatitis C treatment at these 2 sites. And so they excluded people who had decompensated liver disease or some contraindication to direct-acting antivirals. So being on Hep C treatment or initiating Hep C treatment was sort of your buy-in to this study. And then HIV-negative participants were screened for interest in PrEP and offered PrEP based on 2014 CDC guidelines. And they assessed interest in PrEP at all the visits during your Hep C treatment up until the SVR12 visit. And participants were eligible to start on PrEP at any point through week 24. And if they started on PrEP, then they were followed until week 48. And so in total, there were just under 200 participants who were enrolled in this study, and 93% of them were HIV negative. About 63% met the CDC PrEP criteria, and most of that was due to injection drug use criteria alone, but some met sexual criteria only, and a few met both criteria. And then the clinicians who were running the study recommended PrEP to 94 individuals. 29 of whom initiated PrEP. So relatively lower PrEP uptake in this group. For those who did initiate PrEP, the median treatment duration was 104 days, so just over 3 months, and only 8 participants were retained on PrEP through week 48. The most common reason for discontinuing PrEP was side effects. The most common side effect reported was nausea and vomiting, although other reasons for discontinuation included no longer being interested in PrEP, loss to follow-up, medical contraindications, housing instability, and death. So this is a somewhat similar slide to what I showed you in the SSP study, where the authors looked at adherence to PrEP. And so on the left-hand side of your screen, you're going to see the self-reported adherence to PrEP. So the blue columns are self-reported adherence of any pills. Green is 7 pills a week, and then yellow is 4 to 6 pills a week. Orange is 1 to 3 pills a week, and red is 0 pills a week. And weekly adherence to 4 or more pills was reported by 17 participants, so about 74% at week 4, 15 participants or 71% at week 12, 66 participants at week 24, and 5 participants or about 62% at week 36, and then 87% at week 48. But if you look at the adherence measurements by dried blood spot analysis, even though 17 participants had detectable tenofovir at week 4, at week 24, only 6 individuals had any detectable tenofovir. So there was a relatively low persistence on PrEP based on TDF levels. And then the last set of data I'll go over just in terms of PrEP uptake and sustained use comes from our local SHE clinic run by Dr. Dana Reddy. And this was a needs assessment of women in the North Seattle area who were accessing services at the Aurora Commons, which is a day drop-in shelter for people living unhoused. 76 women were interviewed, and then women were stratified by whether or not they had accessed services at the co-located low-barrier clinic known as SHE Clinic versus if they had not yet accessed services. And what you see in the table here is that 49% of the women who had been accessing services at the SHE Clinic were actually had received a PrEP prescription versus 0% of those who did not access services. So a pretty marked jump in PrEP uptake for those who are accessing services. However, I will say that those of us who work at the SHE Clinic know that the really unpublished estimates suggest that about 0 to 5% of patients are actually sustained on PrEP, and that's the biggest issue, is getting folks to take it long term. So, and the last thing I'll just say about adherence and sustained use is, is there anything that we can learn from HIV treatment adherence strategies amongst people who inject drugs, so folks who are already HIV positive? And there was a systematic review conducted by Angela Bazzi where they reviewed 20 studies that looked at HIV treatment adherence amongst people who inject drugs. And the factors that were enabling of ART adherence were really quite variable and are not surprising, perhaps. So folks tended to have better adherence if they were on treatment for substance use disorder, including medications for opioid use disorder, if they had higher reports of self-efficacy, empowerment, and social support. Stable housing was enabling of ART adherence, health insurance, trust in providers, and a good patient-provider relationship, accessibility of healthcare services, and folks who were undergoing a DOT or a directly observed therapy for antiretroviral therapy. Looking forward, I think additional work is needed to help us integrate PrEP services into other low barrier services and other existing harm reduction services for people who inject drugs, including syringe service programs, other community-based organizations, and of course, primary care. And I think specifically more research is needed to understand successful strategies to promote not only uptake, but also sustained use of PrEP for people who inject drugs. I think cabotegravir has the potential to improve sustained use for this group. And certainly, it would be great to see data on cabotegravir specifically for people who inject drugs. Conclusions for the talk today. As you all know, PWID remain disproportionately affected by the HIV epidemic, and there have been several outbreaks both locally and nationally of HIV in this population. PrEP really should be offered to all PWID who have shared any injection works in the past 6 months, or to anybody who has sexual risk factors or wants to be on PrEP. But despite this elevated risk for HIV, PWID do experience a multitude of barriers, both social-structural, stigma-related, that really impede their ability to have PrEP uptake and sustained use. And I think that integrating PrEP into other services, other harm reduction services, whether that be SSPs, drug treatment programs, low barrier primary care, really has the potential to improve uptake, but we're going to need to really focus on evidence-based strategies to retain people in services.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.